So the topic this morning is FXTAS, and we're going to go through FXTAS, learn about what it is, who gets it. I'm Deborah Hall, and I'm an adult neurologist. I counted, I saw 3 here at this meeting, so we're a bit underrepresented. But my training is that I went through adult neurology training, and I see patients in the clinic who have movement disorders. So I see patients with Parkinson's disease, tremors, balance problems, primarily adults. I do have a very small pediatric population. So I am the person, I work with Dr. Barry Kravis at Rush. I am the person who sees the carriers. So I see the parents and I see the grandparents who have neurological symptoms or other issues going on. So I have a FXTAS clinic, which is one of the few, I think, in the country, and a carrier clinic as well. So we're going to walk through FXTAS. Here are my disclosures. We always have a disclosure slide. I do research also on Parkinson's disease, so I have a lot of funding from Parkinson's disease organizations, and there's no conflicts here. So I thought we would start with this plenary timeline. Just to make it appropriate, I kind of themed it for where we are. So on the first day, we heard about the clinical trials for Fragile X syndrome, and of course I've got the young Mickey Mouse here. And then yesterday we heard about problems in women with the premutation, and this is Minnie. And then today I'm going to talk about FXTAS. And so I've learned a lot about the family tree of Mickey Mouse. I spent a bunch of time looking at it yesterday. It's quite complicated. He apparently has about 40 cousins, but no mother or father. So I'm not quite sure how that works. The cousins all have very interesting histories. They are oil tycoons and they're wealthy, that sort of thing. This is Albert Marley. I don't know if I have, oh yeah, here's a pointer over here. You can see here he's got a little beard. And he is in the grandfather age bracket, although he doesn't appear to have Mickey Mouse doesn't have a grandfather either. But they do note that he was rich and very well admired, which is common for Mickey's family members. So this is the age group that we're going to be talking about with FXTAS. All right, so this is the outline. We're going to talk first about the history of the disease, and then go through who gets it, what it looks like, when it manifests, how it changes over time, treatment, and then what the future holds. All right, so I think people have heard this story over the last couple mornings and in the sessions if you're not a researcher in the premutation. The history of this disease is that Rondi, who everyone recognizes, was seeing patients in the clinic in Colorado and noticed that a lot of the Fragile X kids had grandfathers who had tremor and balance problems. She kind of put this together, I think, very astutely and asked Maureen Leahy, who's down here on the bottom in the adult clinic, to take a look at some of these patients with her. And what they discovered is that they had something very, very much in common, and that was their neurological symptoms. They all had the same neurological symptoms. And so the two of them together described this disorder, which is now known as FXTAS. And I always put how we say it up here because it's very interesting what we hear when I get referrals. But it's the Fragile X associated tremor ataxia syndrome, and we'll talk about what all those words mean. So this is a typical family that we would see with Fragile X associated disorders. And so this is what we call a pedigree. Have most of you in the room seen one of these before? Yeah, okay, so this is very familiar to you. So of course the circles are the males or the men, and the squares are the boys. I'm sorry, the circles are the women, and the squares are the men. And what you can see is the dark ones down here are the boys with Fragile X syndrome, and I've got dots for the premutation carriers, so frequently the moms. And then up here in this generation, we've got premutation carriers that are shaded in, and these would be the individuals with FXTAS. So typically grandparents or great-grandparents of Fragile X syndrome children. So this is just a review. You've seen this slide in many forms over this week. And what we're talking about, of course, in Fragile X syndrome is a full mutation with more than 200 repeats at the beginning. The gene, and in this case, FXTAS affects people with a premutation, 55 to 200 repeats. It actually affects individuals with even smaller repeat sizes, and if we have time, I'll talk about that at the end as well. All right, so what's the epidemiology of this disorder? So premutation carriers are more common in the population than individuals with Fragile X syndrome. And the most recent studies by Flora's group and Marcia Seltzer's group tells us that women who carry the premutation are about 1 in 150 women, somewhere between that and 1 in 207 women. And of course, you can see that it's less frequent in men. So this is affecting probably, if we estimate it, about 1 million people in the United States. So it's a pretty large number of people who are carriers. Now, not all of those carriers will have individuals in the family with Fragile X syndrome, but we estimate that that's about how many people this disease may affect in some way, shape, or form. So these are the clinical characteristics of FXTAS. These are the things that we see in the disease. And at the top, kind of going down, are the most common features, and towards the bottom are less common, but things we see. So the first is that the disease was described in men who are carriers, and so still in the clinic, this disease will present more commonly in our male carriers. Onset of the disease is typically in later ages, so usually over the age of 60, although we do have patients in their 50s, much more common as people get into their 70s and 80s. So the patients will have problems with walking, something we call ataxia, and hand tremor. Those are the two kind of main features that we see. Cognitive changes occur. At first, they're kind of mild and subtle, but over time, a proportion of the patients will develop more severe cognitive issues. Patients will have signs that we would see in Parkinson's disease, which I'll tell you about in a minute, numbness of the feet, problems with impotence in the men, hearing loss, and then urinary incontinence. So this is what the tremor looks like in FXTAS. And so I'm a tremor doctor. I see lots of tremor in the clinic. And we try to distinguish the tremor. And this particular type of tremor is a tremor with action, what we call a kinetic tremor. And so frequently in the clinic, I'll ask somebody to touch my finger with their finger. And what you'll notice in FXTAS patients is that it's very shaky. So this is what we call, these are what we call spirals, and this is another way we can get at action tremor in the clinic. So what we do is we give them a sheet of paper that have these spirals written on them, and we ask them to draw with their hand up in between the spirals. And what you can see here is that this is quite shaky. All right, so we would expect that to be nice without any sort of tremor if people were normal. But if you have a kinetic or an action tremor, this is what we would see. Now, this is not the type of tremor we see in Parkinson's disease, which is a very common tremor we see in the clinic. It looks very different. So there's only one other disease that really looks like this tremor, and that's something called essential tremor. It's the most common tremor in the population, and that's what this particular test was designed for. We use a lot of those tests and medications in this disease. Ataxia means without order. It's a Greek word. I always like that taxi is in there, and I always think without order in Chicago, that's what the taxis are like. But in clinic, pretty much it means anything is kind of uncoordinated. So you can have uncoordinated walking, uncoordinated movements of the arms or legs, you can have uncoordinated eye movements, you can have all sorts of coordination problems. So it's just a general term describing coordination issues. So I'm going to play a video for you. So this is the published video of the first FXTAS cases. So these are men who are carriers, and let's look at what they look like.
20, 19, 18, 17, 16, 15, 14, 13.
And there we go. So there's tremor when he's holding his arms out. We call this a postural tremor. And here's this finger to nose. And you can see what that looks like. Here we're going finger to knee, because I think a person taping was doing the exam. And you can see it's a little shaky. And here we go. This is a test we do with pouring water or holding water. You can see that shaky as well. Now, some of these tasks, we're looking for Parkinson's signs. We're looking to see if this is slowed down. And here we've asked him to write a sentence. This is a sample of my best handwriting, and you can see it's completely illegible. And then the tremor again on the spirals.
Like this.
There's another patient with tremor. You can see it with posture, and now we're going to do the finger to nose. This is Maureen Leahy in the tape.
Elbows are out, both of them, and try to touch your fingers together. And touch my finger and your nose and go back and forth.
So there's that kinetic or action tremor again.
And your right hand.
Finger to nose. And we, of course, have patients walk. The most common test I do in the clinic is what we call the drunk test, or what other patients call the drunk test. My patients usually aren't drunk when they come to clinic. But we ask them to walk one foot right in front of the other, the tandem test, and that's a real problem with these patients. You can see this patient looks a little different. He has less tremor, and it kind of illustrates for you how patients do look different. Even though we've got this classic definition of the disease, people will not necessarily have all the features when we see them. And he does have tremor, but it's much milder.
This way? Good. And then up? Up all the way? Up more? Good. And down? Down. Good.
My trip was fine.
Yeah? And tell me more.
It just gets a little boring.
And touch your nose and go back and forth.
I know. Yeah.
And the other hand?
You want to draw? Oh, wait. What are we drawing ammonia in?
And your, yeah, good.
So same thing we're seeing here,
Good.
tremor on finger to nose. And this is
And the other
looking
hand?
for whether people have organized movement. And again, you can see his movements were kind of clumsy, so he has ataxic arm movements. And his balance is a little bit worse. He's a little bit wide, and he's a little bit uncoordinated with his walking. And there's his tremor, and it's mild as well. So I think we could probably, let's quit the video. Okay, so let me talk about a couple other features we see in the disease. The next is what we call Parkinsonism or Parkinson's-like signs. I put a picture of Michael J. Fox on here. I think in this picture he looks like he's unmedicated, so you can see he doesn't have a lot of facial expression. So when his medicine wears off, he's kind of slowed down. He has tremor, which is a tremor at rest. Typically with the hands resting, you will see one of them shaking a bit. Stiffness of the arms and legs and balance problems. And the balance problems look very different than patients who have ataxia. So it's a whole separate set of symptoms that we'll see. So let's talk a little bit about some of the other features in FXTAS. A proportion of patients with FXTAS will go on to develop what looks like dementia. And frequently will start out very subtle. People will have problems kind of with what we call executive function, kind of organizing themselves, putting all the information of the brain together and being able to conduct kind of complicated tasks. Information processing slows down. People will have impaired performance IQ or verbal IQ, and some difficulties kind of controlling behaviors due to the parts of the brain that are affected. Now, it appears that only a portion of patients are affected, and I think we heard yesterday from Rondi that the women look very different. So the women have a much lower, much lower chance of developing dementia. Problems with the cognitive decline seem to correlate with the repeat size, so the larger the repeat size, the more likely there will be cognitive decline, and it's also associated with balance issues. So if you actually have more tremor, you may be less likely to have some of those cognitive problems. Psychiatric symptoms are common, and this kind of goes across the premutation. It's just maybe a little bit more prevalent when you develop FXTAS. So major depression is common. Bipolar, not that common, actually. Patients, it's very split, and it's not all patients, but a proportion of patients will kind of have a change of personality, and people who are very gregarious and outgoing will become withdrawn. That's the most common pattern that I see. Some patients who are kind of mild-mannered will become the opposite. They'll become irritable or agitated. And this becomes a real problem with the marital dynamic. So there's a lot of marital discord that goes on when you have the personality change. So this does happen. It doesn't happen all the time, but it happens enough that it can be hard for families. Frequently, patients will not want to leave their home. So I end up intermittently doing home visits because people won't come into the clinic. And so obviously that makes it very hard to give some of these people medical care. Anxiety disorders are very common, like in other premutation syndromes. And in women with a premutation, we see the same thing in FXTAS. Psychosis is not that common, but can occur in FXTAS. This actually occurs in Parkinson's disease and other movement disorders as well. And hallucinations are a feature of this. So hallucinations in most of these diseases, the patients know they're not real, and actually usually they're not really bothered by them. So I'll be interviewing a patient, and they'll say, you know, there's an elephant in the room with us, and it's not literal. They actually see the elephant, and it doesn't really bother them. And, you know, frequently I don't treat these. But, you know, occasionally someone will come in and say, you know, I see my dead cat all the time, and I say, okay, well, why don't we put you on a medicine for that? And he says, no, I love my cat, and I miss him, and I'm happy to have him in the room with me. I say, okay. So it just depends on kind of what the people are seeing and whether or not they're bothering them. Now, occasionally you'll get somebody who develops a little bit of paranoia. This can be a problem, especially if the patient thinks that the spouse is cheating on them. So there are, you know, times when we go ahead and try to treat this with medicine. You can imagine that that becomes a problem. So nerve and neuropathy issues probably carry across the premutation, but we see it especially in FXTAS. And this may occur prior to the onset of tremor or ataxia. And patients will frequently describe numbness or tingling, usually starting in the feet and moving their way up the legs, sometimes into the hands. And when we do exams of the nerves and the muscle, we find that there is abnormality in conduction of the message down the nerve. So there's clearly something going on here. So nerves are coated with this myelin, and the myelin allows the message to jump very quickly down your nerve. So kind of the message coming from the brain into the arms and legs goes through the nerves. And so what happens is that there's slowed conduction over that system in patients who are premutation carriers. We see some signs of that on exam. People will have decreased reflexes in their feet. They'll have numbness in their feet when we test it. Frequently, you can't feel vibration or other things on the exam. So let's talk a little bit about these patients and where they're ending up. So when the disease was first described, we went back and tried to figure out where the patients were being seen and what sort of diagnoses they were being given. So we did a study. We looked at almost 100 people who we believed to have FXTAS. And what you can see is that they had had a whole host of different diagnoses. Even though they all have what looks like FXTAS with tremor and ataxia, they were diagnosed with all sorts of different things, including Parkinson's disease, Alzheimer's disease, strokes. The miscellaneous category included multiple sclerosis, normal pressure hydrocephalus, a whole bunch of disorders. So it was clear that, you know, it makes sense, right? Because the disease didn't exist until it was described, and so all these people would have to have another diagnosis. But I think that actually this is still happening now. So even 10, 15 years after the disease has been out and we've known about it, I think most FXTAS patients are being diagnosed with something else. And so, you know, I think what happens is that we really are obligated to educate our physicians, and not just the pediatric folks, but the people in the adult world. And so that means taking our family members who have some of these symptoms into the adult neurologist and reminding them that there is these disorders associated with the premutation. So the other issue is that only 5% of these people, these 100 FXTAS patients, had ever seen a neurologist, just even a general neurologist. So that is very, very unfortunate in that, you know, neurologists are very well versed in treating brain disease, and there are a lot of things we can do for patients with FXTAS. Primary care doctors are very good, but they maybe don't have the experience, especially with ataxia or tremor medications. And so getting these folks into even a general neurologist, I think, can be really helpful for kind of quality of life. So I was kind of interested, because there's been a lot of different diagnoses of these patients, of whether or not Alzheimer's disease could be increased in the premutation population. So what I did was I went and I screened an Alzheimer's population to see if I could find carriers. And I used a cohort of patients in Chicago. It's called the Religious Order Study of priests and nuns. So these are people who don't have children, who have been followed for decades over in the Chicago area, and who have donated their brains. And so we have kind of brain tissue confirmation of Alzheimer's disease. And so what we did was we went back and looked at how many of those people were carriers, and there was no difference between the people who had Alzheimer's disease and the people who did not have Alzheimer's disease. So it does not appear that this is more common in the premutation population. So let's just talk a little bit about FXTAS in women. So this is a summary of some of the studies that have been done. So the initial case series came out from Rondi's group, showing 5 women who also had balance problems and tremor of the hands. None of them had the dementia or memory problems, and it was believed that this was due to X inactivation, which I'll tell you about in the next slide. So very recently, there was a study that came out of a European consortium of clinics, and they reported 4 women also with FXTAS, and they felt that the tremor was less frequent and they had more prominent Parkinson symptoms. And the imaging, the brain imaging, looked different than the men. So we recently finished a review of my FXTAS clinic with 6 women, and overall the women were milder than the men and have more of a variety of neurological signs. So I just want to comment on this slide because I think we heard yesterday about problems in women who are premutation carriers. And so I just want to tell you a little bit about what I think is happening here. So FXTAS in women, the disease that looks very similar to the men, I think is probably a similar disease. And a very small proportion of the women, and it's probably less than 10%, they will develop the same sort of problems that the men with FXTAS have. So later in life, they develop tremor and ataxia and problems with cognitive disorders. But I think that the majority of women may not develop FXTAS. And so we hear a lot of women in their 30s and their 40s, and we see them in the clinic. They may have a little bit of tremor or a little bit of balance problem, but I'm not convinced that that's the same disease as FXTAS. I'm not convinced that that is a neurodegenerative disorder. And so I think it's very important for us to remember, even though we may kind of throw out the term FXTAS in women, we kind of want to think to ourselves, okay, well, even though we may use that term, there's probably a whole host of neurological symptoms that aren't FXTAS that the women carriers are experiencing. And I think that's really what Rondi was getting at yesterday. So until we do some larger studies, we can't be sure of that. But even though I'm talking about all this and you're in the room and you're a carrier woman, I want you to know that this is not necessarily what we're talking about when we're talking about milder neurological symptoms in the women. So there's this issue of X inactivation. I think many of you are familiar with this now. This is just an illustration of what this looks like. So at the top we have the zygote. We got 1 X from mom, 1 X from dad. And what you can see is that as the cell divides, one of those X's is turned off or inactivated. And so as the cells divide throughout the body, you're going to have some cells that have the X with the normal Fragile X gene that is active, and then some cells with the expanded Fragile X gene that's active. So women are kind of a combination or a mosaic of these different types of cells. And we think that because women are mosaics with these types of cells, and they have a lot of cells with the normal Fragile X gene expressing, that the phenotype of FXTAS is milder, and maybe that's why a lot of women don't end up having FXTAS even though they live into their 80s or 90s. So I just want to talk a little bit about the heterogeneity of the phenotype. So when the disease was discovered and described, it appeared to be very clear that these people had this exact picture. They have tremor, they have balance problems, and this is what they all look like. But of course, you know, science is never that easy, nor is health and human disease. So over time, what we've discovered is that the phenotype is broader. So maybe that's why all those people were being diagnosed with other diseases. So we reported early on 3 individuals who had perfect typical Parkinson's disease. They had the rest tremor, they were slow, they did not have kinetic tremor, they did not have ataxia, and they responded beautifully to Parkinson's disease medications, but they were premutation carriers. And so the issue is, are they carriers with Parkinson's disease, or is this part of this kind of phenotype when people get older? There have been several patients reported with autopsy findings with low blood pressure, and these folks did have other signs that we would see in FXTAS. One of them had a diagnosis of Parkinson's disease and a lot of falls. And when those people died, they looked at the brains, and the brains were perfect for FXTAS. They had the FXTAS changes. And then there was a case that came out of the California group of a patient who had weakness and increased reflexes, and that really doesn't fit with the phenotype either. So I think that over time what we're going to find is that for many reasons, people don't fit into that classic definition, and we need to really decide, are we going to call that FXTAS too? So this is a disease that becomes more prevalent and more penetrant as people get older. So it's very much like the other neurodegenerative diseases you may have heard of, like Parkinson's disease and Alzheimer's disease, where the disease become much more manifest as you get older. And so this particular disease, we do see patients in their 50s, mid-50s and later, but it becomes much more apparent. The symptoms become much more manifest in those older ages. So actually I saw a woman in her home last summer who Dr. Barry Kravis had published a paper on, I think 10 years ago, and she was completely normal 10 years ago, but now at the age of 95, she has full FXTAS. So clearly she had to live until the age of 95 to get the symptoms, and so this is really what we see with this disease. The older you get, the more likely you're going to have it. And you can see that as you get into the 80s and 90s, for men who are carriers, and this particular graph is for men, the penetrance may approach 100%. We're not sure. Now, I will remind everybody that what happens as people get older is you develop a whole host of other medical problems. And so, when people get into their 70s and 80s, typically even in FXTAS, they get cancers, they have heart attacks, they have strokes, and so that really makes an impact on some of these studies. So the disease does appear to progress over time. So here in this particular study, we looked at change over time, with tremor onset being what we call the beginning of the disease. And what you can see is that it takes about 9 years before patients find that the tremor is impacting activities of daily living, so problems with writing or eating. It takes about 13 years before the writing becomes illegible. And what you will see is actually now this is really less of an issue because nobody's really writing anymore. So I think we probably need to change this to like unable to type or something because that's much more relevant, especially as the population is aging. And then it takes a good 15 years before people really are having a hard time. So they're not able to eat without medication. They're not able to do a lot of their daily tasks. So this is a very long, slow progression. And this is very, very similar to our other tremor disorders like Parkinson's disease, where it's just slowly progressive, slowly changing over time. So the issues with the balance is that usually the balance problem comes on a couple years after the tremor starts, and it takes, not all patients will fall, but those who do, it's usually 5 to 10 years before they start falling. And then 15 years in, they need a cane or a walker. So again, we're talking about very long periods of time. We're talking about a very slow progression here. And again, this is the age group that's dealing with a lot of other things, so orthopedic issues, arthritis, and so there are a lot of factors that kind of play into this. So this is another graph kind of showing progression over time. It's also to remind me that I think this progression, even though we think about it in a linear way, meaning that as you have the symptoms, they slowly change over time. In FXTAS, what we see in the clinic is almost a stepwise progression, meaning somebody will be kind of doing okay, they have a little bit of tremor or balance problem, and then something will happen and they get worse. And there's a clear kind of drop-off that they'll get worse. They'll have surgery, they'll have a major health problem, they'll get cancer and have chemo, and then what happens is that we spend a fair amount of time trying to get back to where they were. And so again, even though we think about it as a linear change over time, it tends to vary a bit. So this is a slide kind of illustrating some of those things, major life events. Even a death in the family can dramatically worsen symptoms in the short term. And then once people kind of recover from that, we'll see that their neurological features will go back to baseline. So acute illness, pneumonia, urinary tract infections very commonly will worsen the gait and the tremor in the short term. Surgery, you heard about that yesterday. Spine surgery especially seems to be a problem in people, and it makes sense if you've got a balance problem and you operate on the spine that the balance would worsen. Cancer and chemotherapy also seem to kind of worsen the symptoms. So I will, we've talked a lot about this surgery and other anesthesia. These phenomenons we see in FXTAS, I see in all of my clinic patients. So it doesn't really matter what the movement disorder is, or whether it's Parkinson's disease or FXTAS. Any of them who have a major surgery or have a major illness will worsen. So this is a very common phenomenon in our clinic. And what I tell my patients, they'll call me and they'll say, Doc, the orthopod is saying I need my knee replaced, should I do it? And my answer is always, to look at the patient and to make a good decision about that. If the patient's not going to be able to walk because they didn't have their knee replaced, then I tell them absolutely get your knee replaced. If they call me and tell me they want to have a facelift, I tell them, well, maybe that's not a great idea, right? Because, you have to kind of weigh the risk and benefit, and we know that the FXTAS symptoms may worsen with anesthesia. So it's really I tell people if you need it, you get it. If it's going to be life-saving, life-changing, it's going to preserve your function, we want to do surgery, even though we may have to rehab you a bit afterwards. So I usually tell my FXTAS patients if you have surgery, warn your surgical team that you will need longer rehab. So the rehab stays will sometimes be double. Instead of 3 days, they'll be a week. Sometimes people will need even longer rehab stays, and the recovery is going to take a bit longer. We can get people back, but it can take a long time. So I had a FXTAS patient who had spine surgery. She forgot to tell me before she had the surgery, and she went from walking to a wheelchair and really could not walk. And it took me probably 6 months to get her back to walking again. So I think everybody's informed and they recognize that this is an issue, we can all work together a little bit better. So we see some changes in the brain in FXTAS that we think are pretty characteristic. And so this is a series of MRI scans of the brain. So we spend our days looking at these, but I just want to orient you a little bit. So the one on the upper left, as if we cut your head open and just flipped off the top. And so what you can see at the very top here is you can see a nose. We have to kind of imagine it. It's kind of hard to see. These are the ears on the side. And these are parts of the nose, the sinuses in the nose. And in here, this is the brainstem. So this is what sits in the very middle of your brain. This is the back of the brain, the cerebellum. And so these little arrows right here are pointing to these little bright spots that are crossing between the brainstem and the cerebellum. And this is something we call the MCP sign, the middle cerebellar peduncle sign. So what's happening is that the back of the brain has to communicate, the cerebellum has to communicate with the rest of the brain. And the way it does it is by sending these fibers into the brainstem, which then go up into the top of the head. And so in FXTAS and a few other disorders, we see an abnormality right in this spot. And not many of our brain diseases do this. So in FXTAS, this is really a sign to us that we should be thinking about this disorder. So we call this the MCP sign. I think you've heard about it a little bit with the plenaries this week. This is a different view of the brain where we cut the brain this way and opened it up. And the nose is here. This is actually the tongue. This is the front part of the head. And so this is the middle of the brain. And what you can see is that there's a lot of black space around here, around the outside of the brain. So this is a picture of a brain that's smaller than it should be. The brain is a little shrunken. Now, I hate to tell you this, but everybody's brain gets a little smaller over time, everybody. So, that's why we need to exercise and do all these other things Rondi was talking about. But in FXTAS, the brain gets smaller at a little bit faster rate. So that's something we see. And then you can see all this white stuff in here. All this white stuff really shouldn't be there. Now, we do see it commonly as people get older. People have a little bit of high blood pressure, cholesterol problems. But in this particular disease, it appears to be associated with what's happening at the cellular level. So these are all the things we're looking at when we look at the brain scan. So we were very interested in some specialized imaging in patients with FXTAS. And so what we did was we wanted to look at dopamine. So dopamine is the chemical that's missing in Parkinson's disease. So Parkinson's patient, the brain's not making enough dopamine, and so they develop this problem with their movement. So what I did is looked at several patients who are premutation carriers in Parkinson's disease to look at the dopamine transporters in the brain, receptors. And this is actually a normal dopamine scan. So you can see this little red right here in the middle. I can't find my pointer. There it is. There, okay. can't really see it. Well, you can see the red in the middle there. Those are the dopamine transporters. If the patient had a decrease on one side, you might not see any red at all. And that's what we would expect to see in Parkinson's disease. So these are people who are carriers with Parkinson's disease. We give them Parkinson's medicines and they respond, but the dopamine imaging is normal. And so what that tells us is that that is not Parkinson's disease. That is something else, not what we typically see in Parkinson's disease. So that, again, is maybe another vote for we're dealing with something other than Parkinson's in the carriers. All right, so let's move a little bit into treatment. So this is, I think, a very key topic. There are no medications that are effective for everybody. And it kind of makes sense because everybody looks a little bit different. And so when the disease, right after the disease was described, we went through to sort out what people had been prescribed. And again, usually prescribed by their primary care physician. And what you can see is that beta blockers were the most common. We use beta blockers to treat tremor, but they're much more frequently given for heart issues. So they're very good for people who have any kind of cardiac problems. They kind of reduce the load on the heart. And so those are prescribed, and that's why I have a little asterisk next to them. Most of those patients were given beta blockers for cardiac reasons. SSRIs, which are medications used for depression and anxiety, so Prozac, most people have heard of Prozac. Those are the drugs in the Prozac family, very, very common. And acetylcholinesterase inhibitors are given for cognitive problems. They're very frequently prescribed in Alzheimer's disease, and you can see that's number 3. Then we have a whole host of medications we would use in movement disorders. So carbidopa-levodopa is dopamine. Benzodiazepines are used for anxiety and for tremor. Primidone is a tremor medicine. Venlafaxine is another mood and anxiety medicine. So you can see there's a whole host of things that people have been given. And when you actually ask them, many of these medications will help about half the patients who are on them. And frequently patients were on more than one medication. So what this tells us is that the regimen for FXTAS is going to vary from patient to patient, depending on what the patient has a problem with. And this is exactly what we see with other adult neurologic diseases and probably what you see in Fragile X syndrome as well. So if the patient comes in with very prominent tremor and that's the issue, then that's what I'm treating. If the patient comes in and they're hallucinating, then I treat the hallucination. So it all depends on what is affecting that patient and what's the biggest problem. So I just want to mention the Memantine study. So this is the first clinical trial now for FXTAS, finished out at the Mind Institute. And it's a study where they looked at 94 individuals. Now this particular medication we would think would work. So this medication is an NMDA receptor antagonist. It is approved for use in Alzheimer's disease. It appears to slow cognitive decline in Alzheimer's disease, although it's not as effective as some of the other medicines we have for Alzheimer's. And it makes sense because there's a direct relationship to the Fragile X protein and the mGluR receptor. And so we believed that if you gave this medication to patients with FXTAS, then they would have improvements in their motor function and their cognition. But apparently that did not happen. And there's probably a number of reasons for that, because some of the secondary measures, the quantitative measures that we did, or I say we did, not we did, the California group did improve. And so measures, very sensitive measures for verbal memory, not testing that you can do in the clinic, but some of the sophisticated testing with the EEGs showed that there was improvement. So I think what we're dealing with here is probably very similar to what we're dealing with in Fragile X syndrome, and that maybe we have to sort out the outcome measures. So maybe we're not measuring the right things in the right way. Maybe we have to really pick our patients, so we got to pick those people who have the exact type of tremor and the exact type of balance problem that we're using for FXTAS before we start testing drugs. So if we start testing Memantine or any drug in a whole wide variety of patients who have what looks like Parkinson's and what looks like FXTAS and what looks like something in between, we may not actually be asking the question in the right way. So I think that this is really a struggle we're going to have in the future. So there are lots of other treatments that we can use. So for motor problems, these are some medications that I'll use for tremor. They're medications that I would use in other tremor disorders. And I do have a fair amount of success with these in patients with kinetic tremor. Sometimes the doses have to be a lot higher. The problem with many of these medications is that they have side effects. Every medicine's got a side effect. And so what happens is that, maybe the myceline works great for the tremor, but I'm making the person really sleepy. So we really have to kind of do this kind of trial in the clinic. I usually will give a medicine, try it for 3 months, and if it's not working, either increase it or change to something else. So the 3-month time interval is what we're using in the adult clinic. Gait ataxia is incredibly hard to treat. It's probably one of the hardest things to treat that I see. And usually my colleagues will send these folks over to me because I have a whole host of things that I do. So when we get through the common medicines, the amantadine, the buspirone, the Sinemet, we get to these uncommon things like varenicline, which is a smoking cessation medicine, riluzole, which is an ALS medicine. These are medicines that are incredibly expensive. No insurance wants to pay for them. So we have a very routine system where we fight the insurance companies, and actually we've got, I think, a pretty good record of getting these for folks, but usually only a small percentage of patients will respond to these. And then for the Parkinsonism symptoms, we actually can do a pretty good job on these. We've got great medicines and a whole host of them that we can use. There is surgery for tremor in FXTAS. So there's a surgery we do very commonly in essential tremor and Parkinson's disease called deep brain stimulator surgery. And it sounds kind of like new age, like, what are you doing? We're putting a stimulator in the brain. And it's really, really interesting. What we do is the patient stays awake in the operating room. We essentially put a hole in the skull and we insert this tiny little electrode into the deep structures of the brain, kind of in the middle of the top of the brain. And we turn it on and it pulsates, and it gives this little pulsation and essentially replicates what a lot of our medications do. And it's got a little box like a pacemaker under the chest wall. We can turn it up, we can turn it down, you can turn it off when you go to bed at night. So it works beautifully for some of these other diseases. So of course, because the tremor is such an impact on quality of life, people started to do this surgery right away in patients with severe tremor and FXTAS. But what we found, especially if you put an electrode on both sides of the brain, the balance problems and the cognitive problems worsened more quickly. And so even though this may help the tremor, we need to be very careful that we don't make something else worse. Okay? So what we're doing now in patients with severe tremor is just putting it on one side of the brain, and we're picking people. And so not a lot of people with FXTAS have had this type of procedure. It's probably less than 20 in the country have had this, but for the right patient it appears to work. And so there's a little picture here you can see on the right. This is this patient trying to draw the spiral. This is prior to surgery, and this is after the stimulator was put in and turned on. This is what they can do now. So it's pretty miraculous, probably for the right patients. So physical therapy is incredibly important in patients who have balance problems, and I usually prescribe it for gait training. The therapists are very good at walking with the patient, trying to get them more stable. I have them do fall prevention, teaching patients how to do tasks without falling. Usually physical therapists who are trained in neurology or vestibular therapy are going to be the best. They're specially trained in the type of balance problem we see in FXTAS. And my colleague, Dr. O'Keefe, who's probably in the room somewhere, yes, she's in the back, she told us about this lovely website, the Physical Therapy Association, where you can just type in your location and it will identify a neurology-trained PT for you. So I think that this is probably useful for folks. I send everybody with FXTAS for therapy. Everybody gets therapy, physical therapy. I usually send for 2 courses a year. Medicare will tell you how many sessions you can get, but we maximize that, and I do think it's helpful with a lot of patients. All right, so here we go, exercise. You've heard about exercise. Exercise we should be doing at all stages of life. Yes, if you're a woman and you're premutation, Rondi says go exercise so your brain can be like Liz's. We heard about that yesterday. But actually, exercise helps everybody, all right? So it's incredibly important to keep moving. If you have a movement disorder and you stop moving, you will not be able to move, all right? So it's kind of move it or lose it. And it becomes more apparent when you develop FXTAS, or if you have a family member with FXTAS, that this is one of the key components to staying ambulatory. So exercise not only will help you keep moving, but it improves stamina, so it increases your ability to be able to do things, and it looks like it increases those memory areas in the brain. It actually causes those areas, the hippocampus, that serve memory to get bigger. to grow. All right, so we really believe exercise has a major impact. Now, we haven't shown in FXTAS that it's any different than any other disease. It hasn't been studied well, but we do believe that it may slow progression of other neurodegenerative diseases. So here's our little mouse. This is the premutation mouse. It's not the Fragile X syndrome mouse running in the wheel. And here's a FXTAS patient. Actually, it's not a FXTAS patient. It's a little young for FXTAS, but it's the same concept, all right? So aerobic exercise, probably weight resistance training is probably just as good. Any of that is good. And, you know, my patients come in and they say, well, so what am I supposed to be doing? How often? I tell them 30 minutes a day, 5 days a week, and they all kind of roll their eyes at me like, oh, that's ridiculous. I'm never going to do that. But, you know, you have the added benefit to those of the American Heart Association recommendations, so the added benefit of cardiovascular health as well. All right, so there's a number of non-motor disorders that we have to treat depending on the patient, and I've got medicines for those too. So we've got medicines for the cognitive problems to try to slow down the memory decline, for psychosis, for the depression and anxiety, for nerve pain, and for dizziness. So we have got all sorts of things that we can use. So depending on what's going on, we'll kind of pick and choose. I usually will do one medicine at a time so that we don't confuse ourselves if there's a side effect, and we will work through this in the clinic. So when does a FXTAS patient need specialized care? So my belief in seeing these patients is that all patients with FXTAS need to see a neurologist. Now, most people are not going to have access to a tremor doctor, a movement disorder specialist. So general neurologists, that's usually what folks are going to be going to see. We have tried very hard to educate the general neurologists. So I am at the Academy of Neurology meetings, which have 30,000 neurologists there. It's huge worldwide meetings. And I think people are starting to recognize after 15 years of us talking about it over and over and over again, people are starting to recognize that this is a disease that occurs in carriers. So we're doing better. Frequently, we will speak to general neurologists. So I will typically talk to people on the phone or by email, and I'm referred patients through the foundation, families who need help. So general neurologists can do a pretty good job, especially if we're all communicating. If you are close to a big city and you can get to a movement disorder specialist, I think that that's even better. Of course, I'm biased, but I think that's even better. And the reason why is because movement disorder specialists are trained in treating tremor and balance problems. Usually they're located at university settings. So, you know, sometimes I'll have patients who see a general neurologist 2 to 3 times a year and see me once a year, and that can work very well. We just work together. And of course, many neurologists, the general neurologists, will need to be educated regarding FXTAS because it's not a disease that they're going to see very often. And if they do see it, it may not have been a person they recognize had FXTAS. So I put this little picture of this kind of nerdy guy here on the right because it reminds me to tell you that adult neurologists are different than pediatric people, okay? So they're different than pediatricians. They're different than pediatric neurologists. All physician specialties have their own kind of personality, right? So, I mean, we've seen Liz and we've seen Rondi, and they're very gregarious and, you know, fun. And so the neurologists are a bit more introspective, all right? So the bow tie is a very common form of dress in my field. The glasses are also very common. The neurologists tend to be a bit more reserved, a bit more quiet. And if you go from a Fragile X clinic to the adult neurology clinic, your head's going to spin a bit and you're going to say, what in the world? It is a very different community of physicians. So frequently we will have families who go to their general neurologist and they say to me, I don't know what is up with these people. Some of it is just the personality of adult neurologists. So I just want to tell you that. We're all a little bit nerdy, you know, and our personalities are a little bit different than the pediatric folks. So just keep that in mind if you're going or if you're taking your family member. And kind of give them a little bit of slack because they're just a different group of people. Okay, so let's talk a little bit about what happens. So you've seen this slide also this week in a little bit different way. So at the top we have the normal Fragile X gene. which is made into this message RNA. And the message RNA in the cell gets translated into protein. The protein is really what's working in our cells to carry out all the functions of the cell. Down here at the bottom, we have the full Fragile X gene, and what happens is that that message is not created because the gene is turned off and you're not making protein. Okay, so you can really see the difference between normal and Fragile X syndrome. But what we have in the middle is something in between. We've got a premutation expansion in the gene, and we do make the message, although we make more message than we need. All right, so we've got excess message, and we make protein. But in people with higher repeats, we make less protein. So there's something definitely going on that's different. It's very different than what's happening in Fragile X syndrome. And that's why people with FXTAS look very different from kids with Fragile X syndrome. It's really a difference at the cellular level. So when we look in the brain in people who have died with FXTAS, you can see these inclusions, and the inclusions are in the brain cells. They're in the neurons, and they sit within the nucleus. And these inclusions we see in all sorts of neurodegenerative diseases and diseases in patients with ataxia. They're very common. I see them in a lot of the patients I see in clinic. And we're not quite sure what's happening in these inclusions, but we think the inclusions are formed of proteins that are clumping up in the cells. Maybe a protective mechanism of the cell to put all those proteins that are clumping up in one spot to try to get rid of them. But we can see them here. This is what it looks like. It's this little pink blob, very impressive. We call it a neuronal intranuclear inclusion. And what our colleagues in the lab have found is that these inclusions actually contain this Fragile X message, all right, this messenger RNA that we're making too much of if we're a premutation carrier. They're sitting in those inclusions in the cell, just as would be predicted. So a little bit about the protein. This is a protein that binds to RNA, which I'll tell you about in just a minute. Lack of this protein really changes the way that the cells in the brain develop. So the spines that hang off of the cells are different than in patients who have a normal amount of protein. We believe that it regulates gene expression directly, interacting with a lot of other genes and proteins in the body and the brain. And it's connected to these glutamate receptors. We keep hearing about glutamate receptors. So for premutation carriers with larger premutations, there's a lower amount of protein, especially as that premutation size gets bigger. And it's been shown that this is associated with anxiety and other social issues in our premutation carriers. So on the right is this little cartoon. This is back to genetics 101. And at the top in the nucleus, we have the DNA, which is transcribed into RNA and then into messenger RNA. All right? It moves out of into the cytoplasm, and it's translated into protein. And the reason why I want to show you this slide is to introduce this concept. So we heard a lot this week about RAN translation. These are slides from Peter Todd, who won the FXTAS award yesterday at the award ceremony. And so what's happening here is that this RNA, the repeats in the premutation carriers, block the ribosome from reading the RNA and turning it into protein. So what happens is that when it's making the protein, the translation is initiated at the wrong spot. And I'm going to illustrate this for you in the next slide. So the translation through the repeat produces this polyglycine protein, which you can see at the bottom on the right is kind of this clumpy thing that you can see. This is what we're finding in the inclusions. So the protein aggregates and again is found in the inclusions. So this is kind of the process as we watch it happen. So here we go. In the normal individual, we're going to make some Fragile X protein, and it's purple. You may not be able to see it, but it's falling off, and there we go. All right? So this is in somebody who's a premutation carrier, and what you can see is here's the repeat, and it forms this hairpin structure. And so when we go to make the protein, you can see, oh, it can't get through. We're having problems here. Eventually it does get through. But what happens is that you make less protein, and this happens especially as that repeat gets bigger. So also what's happening is here when you go to make the protein and you hit the hairpin, you make this polyglycine, and this polyglycine is not formed in individuals who don't have an expansion in normal individuals. And so this is also clumping up in the cell, okay? So you have a problem right at the formation. And that's what's in the cells. So just a few more slides. There is this mitochondrial dysfunction in FXTAS. Mitochondria are the powerhouse of the cell. They generate energy, allow the cells to talk to each other. And this is work done at the Mind Institute where there's a lower expression of mitochondrial proteins, appears to be related to CGG size. The mitochondria may not be functioning as well. There's another story about antisense Fragile X, which is a gene that's in the reverse direction. It's a GCC repeat, and its expression's increased in Fragile X carriers. So anybody in the room who's been in my clinic and given me a skin sample, this is what I was doing. So we look at, in the skin sample, we're looking at this gene. And we think that you not only have to have a premutation, but you probably have to have something else in order to get FXTAS. So you need a premutation plus something, and that explains why only some individuals develop FXTAS at different ages. So this particular with antisense, we think maybe if you have a problem, a certain splice variant of this particular gene, and you have a premutation, that would predict that you're going to get FXTAS. This is just a hypothesis. Dr. Vital, who's probably in the room somewhere in the back, she's doing a study looking at this, so she would be happy to take a skin sample if you'd be willing to do that, anywhere near Chicago. So pretty much in summary, the pathogenesis is that it is incredibly complicated. And fortunately, we have a lot of premutation researchers who are working on this. We've been sitting together in a room the last 2 days, and they're working very hard, and we're moving fast. So just a few new developments. There's another phenotype that I found in the clinic. It's a phenotype that we call progressive supranuclear palsy. These are patients, incredibly rare movement disorder. It's probably about 1 in 500,000 people. And these patients look a little bit like Parkinson's disease. They don't respond to medicine, and they have all sorts of eye problems and falls. I keep seeing this in my carriers, and it's occurring way more than we would expect in the general population. So I think this may be another phenotype that we're seeing. FXTAS does occur in the gray zone. We reported this, and now the Mind Institute has also published papers who have an expansion less than 55 who have classic FXTAS, tremor, balance problems, and abnormalities on the imaging. And then finally, we are now reporting mosaics. So these are individuals with full Fragile X syndrome. As they age, they develop something that looks like FXTAS. So we have both Fragile X syndrome and a FXTAS phenotype in the same individual. And you can imagine this particular man was 71, and he was still seeing Rondi. And I came over and saw him with her, and he looks like he's got a Parkinsonian disorder. And the more I think we follow these individuals over time into their later ages, we're going to find some of them are going to have these more than one phenotype. And when we looked at his cells, he actually had a number of repeats, 540, 447, and 73. And it's probably the 73, the premutation in some of the cells that's causing that second phenotype. So where do we need to focus? Really, my belief is we need to give better care to FXTAS patients. So if you in the room have FXTAS, or if you have a family member with FXTAS, we really need to help all of you to get better care, to get to the neurologist, to get medications, to have people work to improve quality of life. And because I am the only FXTAS doctor in the room, this also tells me we need more people at this meeting so that we can kind of improve the knowledge and the research. We need medication trials. So we have nothing right now that has been shown to be effective for patients with FXTAS, so we have a lot of work to do. We need to sort out this issue of women with the premutation. How many of them get true FXTAS versus milder neurological symptoms? We need to understand better what that is. And I really think we need specialized centers for FXTAS patients, just like we have the Fragile X Consortium. So we've got a little premutation mouse. He looks just as friendly as the Fragile X syndrome mouse, so our researchers hopefully will work on him as well. So I wanted to put in an analogy slide because Liz put in this marathon slide that was so impressive with all these people running. Well, okay, we're not doing as well in FXTAS. So up here on the left, we've got the FXTAS researchers. You can't really tell, but they're standing in a lake getting ready to swim, but they haven't actually gotten going yet. So even though we've had one study, the Memantine study, most of the FXTAS researchers have not organized themselves in a way that we can do clinical trials yet. And then in the bottom slide, there's me looking around, looking ahead here, looking for patients, all right? So we've got to get the FXTAS patients to the neurologists that can do these studies. We need to identify them, and we need to get the carriers who don't have FXTAS in the clinics as well. It is so important that we get everybody together. We're taking blood samples, skin samples, neurologic exams, looking at brain scans, looking at tissues, trying to understand how all of these diseases change over time so that we can help you. And I will say, and it's always an interesting topic to discuss in the clinic, if anybody has any brain tissue taken for any reason, please send it over to one of the FXTAS or premutation researchers. I frequently have people sign brain donation forms in my clinic. I tell people if something happens, we'll take your brain too. So this is the only way we learn. It's the only way we advance the field forward, and we want to help all of you. So I just want to acknowledge this work is done with groups of people, all who are devoted to trying to sort these diseases out, and we're here to help you.